Okay, hello everyone. It's my pleasure to join World Obesity Congress. I'm Ahmed Aosmali from UK. Currently, I'm a higher specialty trainee at Royal Derby Hospital in upper GI bariatric surgery. Actually, our article is talking about the outcome of omega loop gastric bypass after 6 years experience for a large sample of patients, including 1,520 cases. So basically, we're gonna start with the introduction that we all know that the obesity is a global health problem and increasing multiple increasing significantly worldwide and associated with multiple comorbidities, including diabetes and multi-system disease, including reflux, arthritis, cancer, and etc. And as we all know that there is multiple prospective trials and meta-analysis about the bariatric surgery effectively treat severe obesity with sustained benefits long term. And there was many bariatric procedures since 1950, starting by Roux-en-Y gastric bypass and adjustable banding, and ending by sleeve gastrectomy and bilipancreatic diversion. And also, we know that Roux-en-Y gastric bypass remain widely and technically demanding with challenging in technicality and needs more progressing learning curve and multiple complication. That's why the omega loop gastric bypass first introduced by Rutledge, and it is a single anastomosis with just long gastric pouch with a jejunal loop. Basically, omega loop gastric bypass shows promising weight loss with comorbidity remission with low, mid, and long-term complications. So limited comparison with Roux-en-Y gastric bypass, only one randomized trial found similar metabolic outcome and better feasibility and fewer complication. So controversy persists due to is the biliary flux and risk of Barrett's are truly prevent doing mini gastric bypass or not. So our article aims to report the result of large series of primary one anastomosis gastric bypass done and emphasize about the operative outcome as well. So it is a retrospective review at our university bariatric surgery, large one single center, and with the consecutive patients who underwent laparoscopic omega loop gastric bypass from duration between 2009 to 2015, and inclusion criteria according to National Institute of Health consensus criteria, and the multidisciplinary evaluation includes the Barrett esophagus and severe reflux are contraindication to do this procedure and directly sent to do Roux-en-Y gastric bypass. And after we take the informed consent, the surgical technique is, as we all know, it's a five-port approach. We creating a long, narrow gastric pouch with 36 French bougie and using linear stapler anticolic into-side gastrojejunostomy with 30 millimeter stapler and pilopancreatic limb length between 150 to 300 centimeter according to the BMI of the patient. And usually the afferent limb positioned higher than efferent and hanging suture, and routine intraoperative methylene blue checking for leaking test, and drain placed for most of the cases, and no NG tube. Operative time taking from laparoscopic video, and it's the night time. So methodology, post-operative care, early ambulation 2 4 hour post-op, and the diet advanced from water to clear liquids 10 day, and then semi-solid in the upcoming 4 weeks, and follow up routinely multivitamins, mineral, and PPI for more than 6 months, and scheduled visits 2 weeks monthly for 1 year, and then every 3 months, either by phone or online. Results we showed from this large sample who underwent omega loop gastric bypass from this 6 year duration showed that majority of them was female by 62.7% and 37.3% are male patients. And by the end of the study, there is 1,430, which is 94.1% of the whole study sample being followed up for 6 months, and then decreasing the sample size to 73.9% of patients for follow-up just 1 year. and then 680 patients for 3 years. So this graph shows the correlation between the starting weight and BMI, and how we are starting from the weight loss with above than 120 kilogram and reaching nadir till 3 years, 36 months to below 80 kilogram. And the BMI started from between 45 to 47 mean BMI to reach the BMI to 27.5. So this graph also showed the excess weight loss as we reached the nadir at 1 year, and then plateauing, and excess weight loss reached up to 80% after 1 year doing this procedure for the whole study sample. And here the remission for all for the patient who's diabetic, mainly type 2 diabetes mellitus, there are count 683 patients starting by hemoglobin A1C 9.5 and reached at 1 year to hemoglobin A1C below 6, which is a complete remission of type 2 diabetes mellitus. And as we show, the comorbidity and the diabetes outcome at 1 year shows complete remission for 84.1% of the patient, and to 1.1% of the patient showed no improvement of their diabetes status. And this also, the bar chart show the falling in the blood pressure and improving over 1 year, as the systolic blood pressure started from 143 to 126, and the diastolic from 86 to 73. And this is the complication we experienced after omega loop gastric bypass, showing 7 patients showed pulmonary embolism, and the majority of patients, 47, showed iron deficiency anemia. And as we started, it is a retrospective series, as we know that for this large sample of patients, and weight loss was rapid and durable, and also there is a fall in BMI from to 36.5 at 6 months, and started progressively falling till reach in 3 years up to 27.5% with 80% excess weight loss, which is a significant improvement after omega loop gastric bypass. And the overall mortality was 0.1% from 2 cases had a pulmonary embolism, and follow-up rates were 74% at 1 year and 45% at 3 years. So metabolic outcome were strong, and among 683 patients with type 2 diabetes, complete remission reached up to 84% at 1 year, and improving hemoglobin A1C from 9.6% to 5.7%, and reached up to 90.9% at 3 years among the patient who followed up at this time of duration. And among the patient who is hypertensive, 773 patients, we showed that 572 of 622 who followed up for 1 year show complete remission, and increasing this percentage to 91.6% at 3 years among those who followed up. And early complication occurred for 3.3% of the patient, and varies between pulmonary embolism and bleeding and leak, and all managed. And late complication were seen in 6.1%, including majority iron deficiency anemia by percentage 3.1%, and also there is a biliary flux happened to 1.2% of the patients, and no internal hernias were reported during the follow-up period. So overall, omega loop gastric bypass delivered substantial and sustained weight loss, 80% of excess weight loss at 3 years, alongside high remission rates from diabetes, type 2 diabetes mellitus, and hypertension. And this procedure appeared to be practical, shorter, and than many reports from Roux-en-Y gastric bypass, and brief length of stay and low early re-intervention needed. So safety outcome were favorable and very low leak rate, and also there is acceptable complication profile in this cohort, while biliary flux is still present but infrequent. The key limitation of our study include it is a retrospective design, and there is attrition cause. At 3 years, only 45% of the patient sample was followed up at 3 years, and it's a single high volume center setting, which may limit the generalizability. So our conclusion, in our opinion, this procedure is of choice, should prioritize safety and effectiveness. And from this duration, 6 years, which is enough and find many omega loop gastric bypass simple and safe and effective, teachable, and also it is reversible compared to Roux-en-Y gastric bypass, and the acceptable complication and mortality concluding, and it can be an excellent alternative to Roux-en-Y gastric bypass with fewer internal hernia and better weight loss. Thank you.